Yeah, so a 70-year-old man who's complaining of cough and shortness of breath since 10 days, and he was absolutely okay 10 days back. No other issues. But Supriya has found that certain interesting background. So because it's a system to long case, although we have 10 minutes, maybe Supriya can shed more light on his life events. Yeah.
This 75-year-old man is a farmer by occupation.
Uh-huh.
He's from Jangareddy-Gudem.
Uh-huh.
He's uneducated but can read Telugu newspaper.
Right.
He got married at the age of 28 years.
So you mean to say he doesn't write, but he can
But
read?
he can read.
Very good.
He was married at the age of 28 years, and where his wife's age was 17 years. He worked really hard in the field since childhood, as his father got expired at the age of 5 years.
Okay.
He built their own house
Uh-huh.
at the age of 30 years,
Uh-huh.
and they have their own land of 5 acres area now, and he has two children. After 10 years of his marriage life, he gave birth to the first child, his son. His age is 40 years now. He has two children, and they stay at their home place with this family only, with this couple. And his daughter is 36 years old now. He has two daughters. She stays at Kodada, and he gave 3 acres of land to her as a dowry. His son and his family stays with this couple only, him and his wife. But he works in his land and stays in his house, but he won't care about these people. He won't give money for for their expenses. They won't allow to watch TV.
This is the wife's version.
Wife's version.
Okay.
They always scold about the money they have given to his daughter as
So
a
the
dowry.
wife is not happy with him, the patient.
No, with his son.
Okay, the wife is not happy with his son.
Son's
Okay,
family,
fine.
as they are not caring about them.
Right.
They are not giving money for their expenses,
Okay, right,
and
right.
they are not allowing to watch TV also. They are not caring them, as they are living in their house, but they are not caring them.
Okay.
And they always scold about his dowry.
Okay.
As,
So the
as
fact
he
that-
was given three
Yeah.
3 acres of land to his
Yeah,
daughter,
yeah.
they
So
are
they are not
always
happy about
bothered
it.
about
Okay,
that
right,
land,
right.
and they always scream about
So
it.
his sons are not happy, and they are also unhappy because of that. That's the bottom line. Okay, what else?
They became emotional and they cried a lot.
Okay, while they were telling
son
you
and
the
his
history,
family.
they became emotional, and they cried.
He
And
really worked hard in his early days, but he is not happy at his old age
Yeah.
because of his son and his family.
okay, so they're unhappy.
Then,
From that psychosocial perspective. Now, 10 days back, as Arivia said, he was having this cough and shortness of breath. And when he came here, I think Dr. Haripriya looked at his chest. So, yeah, be careful. So, this is the front of his chest and this is the back of his chest. And we will now examine the back. We have, I think, 5 minutes. Kodiga Nilsum Kara. Yeah, maybe correct. Yeah, turn chin. Turn chin. Yeah. Okay, very good. So now we'll have to pull it up. Okay, so now let us. Can you focus on my hand, fingers? Yes, sir. Can you see? There's something interesting happening. I'm not sure if the camera is able to pick up. Can you see anything in the camera? I mean, through your camera? So here what is happening is my left thumb is not moving, my right thumb is moving, and I have placed my entire hands on his chest, in the back of his chest. So it seems as if the right side is moving properly, but the left side is not. Left is also moving, but much less than the right side. So there is some pathology on the left side, and you can see some bandage here. So many people will guess what it is. Now I can show you the sounds. I'm not sure if the video captures the sounds. So we can hear that the sounds here. No, let me do the percussion properly. So here the sounds are less. It's tony dull here, whereas in the same place these are resonant. So normal lung here, abnormal findings here. So this is a classical finding of a pleural effusion. Classical finding of pleural effusion. Is Charan sharing his chest X-ray? Okay, we can sit down. Both, కూర్చోండి. Yeah. So Charan, are you sharing the chest X-ray here? So you can see it's a very, very simple pleural effusion that he has had, and this was all 10 days of cough and shortness of breath. So what is the reason for this? So could it be heart failure or could it be infection? So we did the tap and we found that it has got a lot of cells, mostly lymphocytes, 2,400 lymphocytes, and the proteins were high. It was exudative. We used the light criteria to find out whether it was exudative or not. And it was satisfying all the light criteria, more than 0.7, the protein and LDH ratios. So, yeah. So, everything is fitting into an exudative pleural effusion with a lymphocytic pleurocitosis, and this very commonly refers to tuberculosis. Now, if it was just a pleural tuberculosis, we would have treated for that. But how to diagnose, how to label? I mean, we know from Koch's postulate that the organism should be there. Otherwise, there's a lot of assumptions. We are making some epidemiologic assumptions here because it is common in this part of the world, and that's why it may be. And we start him on empirical therapy. So, should we start him on empirical therapy, or should we try to see what the organism is? We try. We send the sample for CB9, and we also send the sputum for AFB. Nothing has yielded us microbiologically so far. So the biggest question is, should we send him home without any anti-organismal therapy, or should we start him on empirical antitubercular therapy? And we haven't yet resolved this dilemma, which is why he has also got another problem of BPH, which is being looked at by the urologist. So we are thinking that we may have to wait and see, uh, you know, wait for, and we are like trying to look at the parenchymal involvement of the lung, because if you see that X-ray, it's covering up, it's just showing you the pleural part, and you can see a normal part of the lung, but what is beneath or underneath that pleural effusion is what we cannot see. So for that we need a CT scan. So we are waiting for that CT, and if we can see if there is really parenchymal involvement with cavitations and pathology, that will be easy for us to start him on antitubercular therapy. But if there is none, then whether this is just extrapulmonary tuberculosis or something else, we will still be in a dilemma. So what is the time now? Is it 3:30? Huh? 3:25. So we are coming to the end of the session, and I think we'll leave you with this dilemma, and we can work on that in the coming few days if you are with us and if you are in that group. And if you would like to inquire, we will be sharing all these stories that we have. And yeah, so can we have some questions now? It can be general and it can be anything.
Thank you very much, Professor Rakesh, for this. And I can see Dr. Siraj is still around. Yeah. So, friends, you have it. And
Sir, Dr. Firdaus has a question.
Yeah, go ahead. You want to read it out?
Yeah.
You need to unmute. Dr. Firdaus? No, it's not unmuted yet.
Okay.
Dr. Firdaus?
We can't hear, sir.
You lost your video. Oops. Yeah. You want to? Yeah. You want to type the question, perhaps? The chat should be there. Comment. Dr. Siraj, can you see the chat?
Nothing has come in the chat. We have just asked, they have asked her to unmute, but you can still see her hand raised, but there's no video. Yeah, maybe some connection issues. She'll come back. We can see if anybody else has a question.
Yeah. Anybody else would like to ask anything? We have our friends from Rustak also here, Dr. Ajit and Dr. Kohli. Yes, Dr. Kohli. Can you unmute yourself?
Am I audible, sir?
Yeah.
Yes,
absolutely.
Yeah, I had an observation to make regarding that liver abscess case.
Right.
Now, actually, when the clinical things were presented, I was little disturbed. I could not see hear everything. But as I understand, it's a liver abscess, and we were discussing about the method of treatment. Dr. John suggested it should be aspirated. I like to say that these liver abscesses, I don't know what type of abscess. Is it amoebic? It is infective. So whatever, the liver abscesses are known to be very thick abscesses. And if we just, when we say we will aspirate, probably we mean we'll drain and put a tube also. So if we do trans-abdominal aspiration, we won't be able to put a thick, wide enough tube. And they are very prone to get blocked. So I would say it would be a better option to go in, leave laparoscopy, not necessarily open, drain it and put a wide bore tube because they are very, very notorious to get blocked. So if we only do percutaneous aspiration and we will even put a thin tube, it is all possibilities of getting blocked and we will be stuck. So I would say that we should go in this case, maybe laparoscopically, and also at the same time we can look at the stone. We can manage that also in one go probably. That is what I just want to suggest.
Yes, we agree with that.
Very good.
And hopefully we'll be able to show you the re-exploration images as well.
Yeah. Thank you, Dr. Kohli, for your input. Anyway, yeah, I think we've got Dr. Firdos's question. In primary care, sometimes the disease is evolving so clinical signs are difficult to elicit.
Yeah.
I think somebody has answered also from your side.
Yeah. So the clinical signs are difficult to elicit, and the question part. What was the question part of it?
I think what is being said is in ambulatory settings where you don't have so much time to reassess and assess repeatedly. Perhaps the clinical examination, the first sitting may not be as good. And therefore, how does one go about it? I think that's what is being said.
Okay, right. I got it. And it's a very important question. So I think not only just I think there is a lot of evidence that it's not just the most important is the sequence of events of the patient's journey as it evolves. So when the patient starts from a point A and goes to a certain point when he comes to the physician, point B, let us say, a lot has already happened. And that is the time the primary care physician has to figure out as to what the diagnosis and planned therapy is. So most of the time it is that data, the event data, which will help the physician, and we call that loosely as history. And it can be so many layers of history like biological history, psychosocial. So that is a very, very important. 90% of the time, the diagnosis will come from there. Now, what happens is, as we already showed you, the next few clues to the diagnosis will come from the examination, clinical examination, and the final, the strengthening, the putty or whatever you call it, you just strengthen the entire foundation by confirming it with a few investigations, which will give you a better visual idea of the anatomic area involved and the pathology involved and the possible etiologies. So when we talk about investigation, it is not in isolation. Like, often what happens as physicians is through WhatsApp or whatever, people just shove a lot of reports into our face and then say, just tell me what is wrong with me. We say we can't tell you anything seeing those reports. I mean, they're just a bunch of numbers. So we have to see you in entirety. What happened to you? When were you completely all right? And what happened after that? And why did you get these reports done in the first place? So this is a very, very common issue that we have to deal with in a daily basis. So yes, investigations are very, very important for strengthening our foundation, but we have to reach that level. We have to first make the house. And the house is made by the sequence of events, which needs a very, very patient listening and on part of the physician and building up the entire story, the illness script as they call it, and followed by the clinical findings. And when we say clinical findings, you can also include the investigation. So what we mean that about clinical findings and investigations, that is internal medicine. That is what we see inside the body. But there's a huge area of external medicine which is not inside the body but is influencing the body. Whatever the body is showing you is all because of the external factors which is influencing it. And that, of course, nobody calls it external medicine, only I do. And probably it's better called as community medicine, primary care. But essentially, they're all the amount of environmental, exposures that the gene or whatever the protein product of this body is being exposed to. And that combined effect is what is in front of you.
Professor Rakesh,
Yeah.
in your own example, you mentioned that, the first time you saw this patient, you thought the gait was equine, and then later on, when you evaluated the patient, you had a different opinion. And perhaps even as this video was going in also, you were sort of, it was sort of shaping up in a different way.
Exactly.
And now you talked about system 1 pattern type recognition and also system 2 where it's more about thinking. And trying to correlate it with Dr. Firdos's question on primary care, would it be fair to say that sort of the primary care, because she's a family physician, by the way, in family care, would it be more sort of focused on, when you teach students, particularly on pattern recognition?
Which is system 1 in a way. Yeah.
Would that be a fair thing to say, or?
Well, I would think that primary care needs system 2 more than system 1. System 1 pattern recognition is a kind of expertise which you develop over time when you repeatedly do the same thing again and again. And nothing is stopping a primary care physician from doing that, but it's basically practice. The practice of medicine is what keeps on building up in installments in our brain. And as soon as we see something, we can immediately recognize the pattern, and we cannot explain it either as to why we are doing certain things. In system 1 thinking, it's like that. System 1 thinking is essentially no thinking. It is just pattern recognition and reflexly doing certain things. And it's very useful when you need to take quick decisions in emergency situations. But in a primary physician's chamber, it need not be always necessary. What is required for a primary physician is to spend a lot of time with their patients, which is of course always short, but it is very, very essential that we primary physicians spend a lot of time and take out all the kinds of biological, psychosocial events that has gone in the patient's life, and then become a part of that journey which they are experiencing and suffering from.
Thank you very much for that. Anybody else would like to ask or clarify any doubts or? Yeah. Dr. Suraj?
Nothing from my side, sir. I must thank Dr. Rakesh, and as you rightly said, we will have this association, built in firmly, so that some of our colleagues couldn't join because they had academic assignments, and Dr. Rakesh insisted, let's start today. So we'll be looking forward to further iterations and how we can take this forward. But I must